Good evening, friends. So, I'm Dr. Kaladhar, Senior Consultant, Head of the Department Critical Care Medicine from Yashoda Hospitals, Malakpet. Welcome to our masterclass series from Department of Critical Care Medicine, Yashoda Hospitals. This is well across received. It benefits IDCCM and DRNB Critical Care Medicine students a lot. Today the topic of discussion is DKA and HHS. For this, I welcome our senior and seasoned clinicians and teachers, Dr. P.L. Gautam sir, who is a professor and head Critical Care Medicine Department from Dayanand Medical College and Hospital, Ludhiana, Punjab.
Good evening.
Sir?
Good evening.
Good evening, sir. P.L. Gautam sir, welcome. Good evening, sir. And Dr. Supradip Ghosh sir is a Director and Head, Department of Critical Care Medicine, Fortis Escorts Hospitals from Faridabad. Welcome, sir.
Thank you.
Yes, sir. So to present this case, we have two students, Dr. Shwetha and Dr. Hemalatha. Both are IDCCM students, sir, from Yashoda Hospitals, Malakpet. So they are going to present, sir. You can, like, in between, anytime you want, just intervene and ask the questions accordingly, sir. Thank you. Yeah, Dr. Shwetha and Dr. Hemalatha, please proceed with your presentation.
Good evening, sir. Good evening, sir.
P.L. Gautam sir, good evening.
Good evening, kaise ho? How are you?
Bhaiya sir.
Yes, Shwetha, you can continue.
I'm sharing the screen, sir.
Yeah.
Sir, is my screen visible, sir?
Yes.
Yes.
Good evening, sir. I'm Dr. Shwetha, and she's Dr. Hemalatha. We are IDCCM students from Yashoda Malakpet. Today, we are going to present a case about a 25-year-old female resident of Hyderabad who came to the ER with complaints of shortness of breath and altered behavior since the previous night, one night duration of history. Patient presented with complaints of shortness of breath, grade 3, sudden onset, no complaints of orthopnea, chest pain, palpitations, altered behavior since night, no complaints of, no history of seizures, trauma, no fever and vomitings. On taking further history from the family, they revealed that she had a history of dyspepsia, pain abdomen, periumbilical area since 1 week, for which she was visiting the gastro OPDs. In view of the same, she even underwent a upper GI endoscopy for the same 2 days ago, which showed mild gastric and duodenal erosions. On taking the further history, she is a type 1 diabetic, medico, with no addictions. Family history was not significant. General examination showed she's moderately built and nourished, no pallor, icterus, clubbing, cyanosis, and pedal edema. On arrival to ER, she was drowsy but arousable to calls, obeying commands, and slightly restless. Her pulse rate was 117 beats per minute, regular in rhythm. Blood pressures were 80-50. Respiratory rate was 36, tachypneic. Maintaining saturations of 96 on room air. She was afebrile with GRBS showing us 583, which was high. On systemic examination, respiratory system, bilateral air entry was present, no added sounds. CVS normal, no raised JVP, S1, S2 heard, no murmurs. CNS, she was drowsy, arousable, and obeying to commands. GCS was E3, V5, M6. Pupils were bilateral 3 mm reacting to light. Abdomen soft and bowel sounds heard. No other abnormalities detected on further examinations. Coming to initial management in the ER, she was holding the airway.
Can I interrupt, please?
Yeah, sir.
Sure, sir.
A few things. You said that this patient was had a sudden onset of dyspnea.
Yes, sir.
Do you mean whenever we say sudden onset, it has
Yes.
to be sudden. Sudden is either an electrical event or a vascular event. Anything, any system. If there is a sudden, it has to be electrical event like seizure, like arrhythmia, or it is a vascular event like pulmonary embolism or myocardial infarction or stroke. But your history and subsequent history doesn't suggest anything that it was sudden. So you should be careful while using these adjectives like sudden. Okay. So it was probably a gradual onset.
Yeah.
Second thing, you said that there was respiratory dyspnea and respiratory distress, apparently. But
Yes.
your clinical examination doesn't suggest anything like that. You said you didn't mention anything about the respiration, what was the type or pattern of breathing. You did not say anything about is there any finding in the respiratory system examination. You said that there was no added sound, there was air entry was equal. So your history and clinical examinations are not correlating with one another. That so whenever you say something, that must be justified. Okay.
Yes, sir. Ante like even sudden onset can be because of any pneumothorax or air embolism. So I have just mentioned that air entry was equal, and yeah, further respiratory examination proper was not mentioned here. Okay. The history was given for 1 night duration, sir. Probably ante the family gave the history. So
You can say acute onset, maybe over a period of few hours, few days. Sudden means all of a sudden. It's within seconds. It's like a cluster. It's like a cluster headache. Sudden onset.
okay, sir. So acute onset breathlessness.
Yeah, acute onset maybe over a period of few days, or you may use some descriptive terms like overnight she becomes more breathless. There was some pain abdomen for a few days for which she underwent some endoscopy also. Apparently, no, that's what the history is.
Shwetha, you said that patient has a pain abdomen and patient is non-diabetic.
Yes, sir.
So she's diabetic for how long? It's childhood started, but she's now 25, 28. So when was the first episode she was diagnosed to be diabetic?
We have a history that she was using, she was on her medications, got diagnosed by her 10th class, 8th, 9th class, sir. Probably around
What was her first presentation?
16 years, probably, sir.
What was her first presentation at that time?
Not taken that history, sir.
So you said now this patient is presenting with breathlessness. If patient is a non-diabetic, that too insulin diabetic dependent, and patient is coming with the pain of abdomen. What are your suspicion now coming up with this patient? When you start with the NIV directly, that's okay. Supportive therapy we can start immediately. So what can be the reason for this distress you can think of? A patient coming with the non-diabetic, then coming with the respiratory distress, and that too without fever, without anything, but pain abdomen. What are the possibility you will think of for differential? Because while you have any complaint, you always give couple of differentials like ChatGPT.
Yes. It can be acute pancreatitis. It can be DK per se, which is causing which is a pain abdomen is even a symptom of DK. Pancreatitis is one thing.
So now your sugar level, this patient was having 600 plus, and patient's history is a couple of days. So what are the possibilities of diabetic patients having such complication when the patient's having both things together, like couple of days are there, it's not that acute, and patient's glucose level comes random more than 600.
HHS can be a possibility.
Pardon?
HHS, sir, non-ketogenic diabetes.
So now coming, what is more common in this type 1?
Type 1 diabetes
or this one?
No, DK is more common in type 1 diabetics.
Maybe she skipped the insulin doses, sir. Maybe one of the precipitating causes. Omission of insulin may be the one of the
poor compliance. That's good. Okay, go ahead.
So she was tachypnic, so initially kept on NIV to reduce the work of breathing, and fluid boluses of about 2 liters.
She was conscious or unconscious or drowsy at that time? She was drowsy, something like that?
She was drowsy, sir, but like responding to the calls.
Her GCS was around 13, 12, 13.
Yes, 13, sir.
13.
Yes,
Yes, 3, 5. And, so what about the NIV? How safe is NIV in a patient who is drowsy?
Not that safe, but initially to stabilize it, at least to reduce it, to stabilize it, we have kept her on NIV and shifted from ER to ICU.
Any other alternative to this in such a patient?
To intubate, but not she doesn't meet the intubation criteria yet. At least to secure with a nasal airway or something initially. And
Nasal airway is not a patient who is having GCS of 14, 13. Unless until there is airway obstruction, nasal airway is not required.
Yeah.
Nasal airway is purely for either area of obstruction or tongue fall, is there something like those things, not these patients. What about HFNO? Can we substitute with that, or it's not of use?
HFNO will, when compared to NIV, it doesn't reduce the accessory muscle work of breathing that much.
Hey, where the work of breathing, you said that reduce the work of breathing. NIV versus HFNO, which reduce the work of breathing more? And what about the dead space compensation with the both techniques?
HFNO then. HFNO.
Work of breathing is reduced by NIV more, better way. Because
Yes.
increase the expiratory reserve volumes. HFNO is better to wash out the dead space only.
Dead space reduction is.
You know how much dead space is washes if you increase 1% of flows?
Not that idea. Sir.
It's around 1.8 ml of dead space is washed out. If you go around 30-40 ml, it will take away around 50-60 ml of dead space. Okay, go ahead.
So we have ordered the investigations like urine ketones were done, ABG, normal hemogram, complete urine examination, electrolytes, creatinine, coagulation profile, ECG and echo, and one chest X-ray. So the lab showed, yeah.
Yes. Okay, you go ahead with the investigation. Okay, we'll discuss. Okay.
The lab showed high GRBS, urine ketones large positive, ABG with severe metabolic acidosis with pH of 6.7 and bicarb of 3.
So the end blood sugar is not high, but the ketones are high.
Sir?
This patient is having RBS very high and ketones are large. Large mean?
4 plus.
4 plus. Okay.
Plus.
So suppose the glucose comes normal, but the ketones are high.
Yes, sir.
Is possible?
Yes, it is possible. They can be
So
used.
what are the patient you will find such a thing?
Who are on glifloxacins, medications.
That's good.
And any alcoholic patients.
But those are patients on type 2 actually.
Yes, yes, sir.
Anything else which is possible, which can lead to
starvation ketosis? Starvation ketosis can also be present.
Diabetes.
Starvation. Anything else? Nearby starvation ketoacidosis, which produces low glucose levels. Because these days males, females are equal. Women empowerment is full.
Alcoholic intake.
Well has passed.
Pregnancy with diabetes, sir.
Alcoholic intake.
Alcoholic, yes. Okay. If you go think of alcoholic, which patients get more of such picture? Alcoholic, patients who are chronic alcoholic or patient who take the binge?
Alcoholics.
Okay. Go ahead.
No, I can't see the bicarbonate. What is the bicarbonate level?
Sir, it is 3.9, sir.
And what is the PCO2?
PCO2s are 9.
9.9.
9.9, sir.
Bicarbonate is 3.9.
Yes, sir.
That's what you say? So is it only purely a metabolic acidosis, high energy metabolic acidosis, or there is something else?
Mixed pattern is there, sir.
Respiratory alkalosis is also there.
Respiratory. That's all? There is no third disorder? Have you calculated?
Sir, sorry?
Have you calculated for the third disorder?
Third
So
disorder.
how do you say? I'm just interrupting. How do you say it's a respiratory alkalosis? Compensated or what is the expected CO2 level?
It is it should be 1.5 into bicarb
plus
8 plus or minus 2.
2.
So what is expected in this patient with the bicarbonate of 3.9?
Around 14.
12.5 plus or minus 2.
But it is
10 to 14.
Around 14.
Yes.
And it is low. But probably, okay. Okay. And what was the RBS?
RBS was 583, sir.
583.
83.
Urine ketones were
4 plus. Large 4 plus.
okay.
Echo was also done, which was showing global hypokinetic LV with moderate LV dysfunction, EF of 45, moderate MR, no pulmonary hypertension, vegetations and clots.
So how do you explain this global hypokinesia?
The severe acidosis causing cardiac suppression and myocardial feature.
So what was the potassium in this patient?
So potassium was 5.6 initially.
5.6.
Yes, it was in the next values.
Okay.
So coming to the electrolytes, creatinine was 0.6, sodium was 138, potassium was 5.6, and chlorides of 98. Troponin was positive 1.09. Lipases were also done as she was having abdominal pain complaint to rule out pancreatitis. It was normal 92. TLC were raised 30,000. CUV, which showed only 3 to 4 pulses.
So just hold on here. You got lipase said to rule out this pancreatitis. Lipase milase is investigation and diabetic ketoacidosis good investigation to rule out pancreatitis, or it's poor investigation to rule out pancreatitis in diabetic patients, especially diabetic ketoacidosis.
Not that a good indicator.
So how do you rate this? How do you rate it? What is the role? And how do you explain it? What should be done then?
Radiological investigation is better.
CT image.
Yes, this can be lipase milase can be falsely mildly elevated in patients with diabetic ketoacidosis without this.
So I should go for a radiological
Now,
investigation.
how do you explain this troponin? It's high, no?
Yes, sir, it is positive.
Yes, how do you explain it?
Underlying stress may be the cause.
Stress-induced cardiopathy.
Yes.
So, what is a stress-induced cardiopathy? How does it look like stress-induced?
There should be apical hypokinesia with basal hyperkinetic movements of LV. Ballooning like picture on echo.
Very good. Apical ballooning. Marker can be up. So any short investigation to rule out, although this is not status where the patient, we would subject patient for investigations, especially when the acidosis and high potassium is there. Okay.
Okay.
Go ahead.
So initially treated with IV fluids, we started IV fluids. As potassium was 5.6, we did not correct it. Gave insulin 6 units IV bolus as taking her weight as 60 kgs, and kept on a maintenance infusion as 6 units per hour. In between, given a bolus of around 1 liter crystalloids again, taking the focus and all in consideration. By around after 2 hours, the acidosis was still persistent. Oxygenation was good. She did not land into overload. Received around 3.5 liters of crystalloids till now. Her BP was still 90/60. Urine output was okay by this time. Later, the patient became more drowsy. So had to intubate her and keep her on mechanical ventilation with supports. Initially started on 100% FiO2 and later came down to 40%. PEEP of 6, respiratory rate of 24, and tidal volume of 380. As she was tachypnic earlier, so we had to maintain the high tidal volumes to compensate it. Insulin infusion was continued at 6 units per hour. IV fluids at 200 ml per hour in the first 2 hours. Blood and urine cultures were sent to rule out septic foci. Antibiotics were added as initial TLC were high and procal was also elevated. Started on rice tube feedings. Added enoxaparin for DVD prophylaxis.
So, Shwetha,
Yes,
when
sir.
the patient's pH is 6.8, 6.7, like your patient, and where the CO2 is around 9, and what are the precautions you will take when you are taking the patient on ventilator? Setting is okay, but should be the way of intubating such patients so that we can avoid the cardiac arrest, because patients potassium is 5.6, patient's pH is 6.8, and patient is having GCRs of around 13, 14 or 10 even. So how will you go with the intubation? Because such patient can collapse during putting on the patient on ventilator.
It should be a rapid sequence intubation, sir.
Sedate
Sedate with the fentanyl.
fentanyl, and we will use the paralyzer.
Because this is a physiologically difficult intubation as such. So how will you take care of this physiology?
We'll keep aside the difficult intubation airway devices like supraglottic devices like laryngeal mask airway.
See, my question is a little different. One is anatomically difficult airway, one is physiologically difficult airway. This patient's airway is physiologically difficult because when we are intubating such patient, when the pH is 6.8, CO2 is when you are going to intubate such patient, you are going to give some drugs also. And patient is already having a not very high blood pressure, and potassium is 5.6 something. Like our drugs, our way of ventilating during intubation when you are going to paralyze or putting the patient on this. So what are things which you will very take care of so that patient should not end up with cardiac arrest? Patient can go into hypotension, a little bit of retention of CO2, which happens because of your patient may be breathing 30-40 rate. There are a couple of conditions where it's very important to maintain the same rate what the patient is breathing off.
And for sedation, we can use we can use fentanyl and accommodate if the BP in case of severe hypotension, and rocuronium for paralytic agent because of the short acting of muscle relaxant. We can't wait more for muscle relaxant to occur. So like that we can avoid hypotension and even severe retention.
Normally, the rapid circular induction is without with the apnea. Actually, these are a patient where we should not wait, because a little bit rise in CO2 level will have a drastic down in the pH.
Will worsen the respiratory.
What about the bicarbonates? Can we give soda bicarbonate with this patient?
The pH is ideally 6.5, sir. So can it is an acute situation, can given as a bolus, but not suggested as a maintenance thing. We have given actually because it was not getting corrected. The pH is still around below 7. So we have given a start dose of soda bicarbonate.
Carry on. Good. Very good.
The next stages after 2 hours was showing a pH of 6.9. Still base exchange was high. It was -25. Bicarbs are low. Metabolic acidosis persistent. So at this point, we gave a soda bicarb for 100 ml stat. And serial ABGs and sugars were checked secondarily. The pH was slightly settling, but anion gap is still high. It was still persisting. At like around 6 hours later, metabolic acidosis was pH was settling. It was getting compensated. Base exchange is slowly coming down to -15. So serial ABGs were done fortnightly, and by day 2, this was the scenario. pH was 7.2. Base exchange was still -16. It was the acidosis was still persisting. And there was a hypokalemia also, 3.2, that was the potassium. So we have given potassium chloride corrections with 40 milliequivalents correction, and the potassium electrolyte levels were also monitored. Sugars were checked second hourly. Infusion was continued. RT feeds we have slowly increased to 50 ml. Ventilator settings were maintained at the same. There was no drop in the PF ratios. Oxygenation was good. Norad slowly weaned off. Urine output was adequate. She was slightly restless on ventilator. So analgo sedation with fentanyl was continued. By day 3, pH was still again 7.2, but the base exchange was getting lower. Bicarbs were improving. It was 10 now. Urine output was adequate. RFTs were normal. hypokalemia was still there, so we have added potassium chloride in the IV fluids which were being given. Artifeeds were slowly increased. Hemodynamics were better stable.
Suppose the patient's glucose level is coming around 70, 80, 70, 80, but the ketones are positive. So how will you manage?
Ketones were positive and sugars were?
Patients are positive now, still going 2, 3 plus, but patient is AB showing gas doses, but the patient's RBS is coming around 70, 80, 70, 80 on the lower side. So what will you do?
The anion gap should be corrected, so insulin infusion should be continued, but along with dextrose solution should be supplemented along with this. Ketones need not be traced for correction. Ketones will, however, be positive. They'll still persist for 2 to 3 days. So that need not be tracked or traced. It is
possible to have normal ketones, but the diabetic ketoacidosis. Very difficult question.
Normal ketones. I've never seen such.
It's a difficult question. This is possible because what are the different ketones in the body?
Beta
Goes into ketoacidosis.
Beta hydroxybutyrate, acetoacetate, acetone.
So they are in the same amount at all stages of diabetes?
No, sir. They are 1:1 level, but in DKA, their ratio will be changed to 10:1.
Beta hydroxybutyrate will be more predominantly increased.
So it's very important to understand is because all your glucometers or ketones investigations are use the same sort of principles. So it's possible. What is the relation of again? In COVID, we have seen a lot of these patients. We have faced the problem also. What is the relation of vitamin C? Sometimes people are giving with this glucometers investigations. A patient is given vitamin C. Is there any interpretation problem with the thing?
Vitamin C, it may be given as
the
an
patient is receiving vitamin C high dose. Sometimes it has been given, was in the guidelines also. In COVID, we have given a lot of even the sepsis. Is there any interference with the interpretation of the investigations or the falsies in the glucometers?
No idea, sir.
No idea. So what happens is, if you see, these are oxidizing agents, which are the principle of glucometer, especially the echo check and all these things. But if you go with the investigation in the lab, rather than the point of care testing, they will show hypoglycemia. Some of patient has falsely labeled hyperglycemic with vitamin C who are hypoglycemic. So one should be very careful if patient is on vitamin C, then we should get in between, especially on the ventilator. There are a lot of reports where the patient has gone into hypoglycemic insult to the brain when the patient has been receiving vitamin C and they were giving the insulin because it was showing high glucose levels. Good. Carry on.
By day 4, the pH was settled. Bicarb basic change was slowly reduced. Bicarb came to 15 plus. So insulin infusion was stopped and the subcutaneous doses were given. IV antibiotics continued and fluids were reduced. We have given a trial, SBT trial, and she tolerated. So extubated to NIV pressure support ventilations. Urine output was adequate. Vitals were stable. By day 5, the acidosis got settled. Sugars were a bit fluctuating, but managed with subcutaneous doses. Cultures came as sterile by this time. Encouraged oral feeds. Echo was repeated and which showed improvement in LV functioning. EF was 53 now. IVC was dilated. Mild LV dysfunction was there. No other issues events occurred during this period. By day 6, the labs were okay. She was weaned off from NIV. Respiratory distress settled down. settled. She was maintaining on room A. Vitals were stable. So we have shifted her out of the ICU.
Good presentation, Shwetha,
So,
and your colleague, friend. Couple of points I would like to understand as an examiner, and I want you people to know as an examinee. First of all, whenever we discuss diabetic ketoacidosis, or for that matter, any endocrine emergencies like mixed edema, coma, thyroid crisis, all things, we always need to understand what is the precipitating factor. Okay. From your case, I could not understand what was the precipitating event in this lady. Usually, a diabetic ketoacidosis is precipitated by some sort of infection. I suppose you have suspected that, and you have given some magnet code empirically for it.
Yes.
Though you don't have any documentary evidence in support of the infection, except some rise in the procalcitonin and some minimal rise in the TLC of 12,500 in the first thing, which can be by any stretch. Was there any ischemic event, both in the myocardium? There is some rise in the propi. You don't mention anything about the ECG. Your echo findings is not suggestive of any regional wall motion abnormality. Why was she drowsy? Is it only because of diabetic ketoacidosis? Very unlikely. I've been practicing medicine for 30 years. I have not seen, and I'm a medicine guy, so I have not seen diabetic ketoacidosis patient being so drowsy that this patient requiring ventilator support. So we need to understand why this lady was so drowsy. Was it some electrolyte disturbance, or was there any small stroke, or was there anything else? I don't know. So your thing should focus on this. Or it can be usually in younger children. It can be because of withdrawal or not taking the insulin dose.
The family.
Family.
Actually,
Let me finish and then you can come back.
yes, sure.
Okay. So this is important. Your history and clinical examination and your investigation should focus on the precipitating cause of diabetic ketoacidosis. Regarding the presentation, one I pointed out, sudden. Beta, yes, sudden nahi hota. Cannot be sudden. It has to be okay for a few hours, but it's not sudden. Second, I would like to emphasize that whenever you take history again, you should emphasize on this precipitating event. Your history should focus on both in your exam and your real life practice. Your investigation, you mentioned your ABG was it was so small that old people like us can't see it. At least I can't see it. So you should make it little bigger. And you mentioned hug mark. But when as a student of intensive care medicine, whenever you first present your ABG findings, that should be comprehensive. Like you could make out that there is a respiratory alkalosis. And whenever you mention hug mark, the anion gap, how was the anion gap? How much was the gap? That is very, very relevant, because anion gap is the one which you are supposed to follow, not pH, particularly in diabetic ketoacidosis, because when to start oral feeding, when to start subcutaneous insulin, all depend upon your normalization of the anion gap, right? You mentioned about the electrolyte. What is electrolyte? What electrolyte? Sodium, potassium, magnesium, phosphate. There is no mention of magnesium and phosphate in your presentation, which are very, very essential for the diabetic ketoacidosis. True. We need to understand why we want to give magnesium, why it is important for them. Your patient has got hypokinetic LV, and this could be because of metabolic acidosis. Of course, it can be because it was very severe, but it could also be because of deficiency of phosphate. I don't know, because you have not mentioned. Takoshubo cardiomyopathy, I must say, you have mentioned about Takoshubo. It is not necessary that Takoshubo cardiomyopathy or stress cardiomyopathy always has to be with apical ballooning. Not at all. This tropi elevation was because of hypoperfusion of the myocardium, and it is very, very common in critically ill patients. So doing tropi rampantly is not advisable in critically ill patients. If you do tropi investigation, it's a very, very sensitive marker of myocardial damage. You will find 100 out of 100, at least 70 patients will have tropi elevation in the acute stage. Does it mean everybody required a coronary artery? No, this is some damage to the myocardium. So you can actually avoid it. Finally, there will be questions regarding which fluid. Somebody has asked us in the question and answer. What type of fluid would you like to give? Okay. How much fluid would you like to give? Shall we give empirical fluid? Shall we give fluid as per the hemodynamic requirement of the patient? Shall we personalize the fluid? You mentioned about saline given in the initially, and later on it was switched over to ringal lactate. Why ringal lactate? What is the problem in pediatric age group? What is the problem of cerebral edema? Cerebral edema is a known complication, in particular in pediatric ages, not in adults. That is the reason in the pediatric population they prefer saline, whereas in adult population we prefer saline salt solution. There will be a question on electrolytes, as I mentioned. When to give potassium, when to give phosphate, when to give magnesium. There will be a question of when to start insulin. Shall we correct the hypovolemia first before giving insulin? Shall we correct hypokalemia first? In your patient, the initial potassium was 5 point something. So there is no problem giving some insulin. But in some patients, it may be some borderline. ABG mesh for a potassium of 3.2. Will you start insulin? It will precipitate the hypokalemia. So these are the questions which will be coming to your exam. And obviously, there will be some questions regarding the differentiation between hyperosmotic, hyperosmolar non-ketotic stage, HONK, and diabetic ketoacidosis.
Supradip sir.
There may be, if you do,
Supradip sir.
last minute, just last comment. If you
Supradip sir,
answer,
can you listen to me, sir?
yeah.
Yeah, nothing, sir. Sorry to interrupt. You can ask question one by one to them, sir. They will answer.
I'm just giving a perspective. Question can be asked. I'm just giving a perspective what is expected from them in the IDCCM exam. They are IDCCM students, so these will be asked in the IDCCM exam. And lastly, if you answer these questions very nicely, then you may be asked about the there are some conditions where you may get ketoacidosis with a normal blood glucose. Ketoacidosis is a normal blood glucose with the newer SGLT2 inhibitor. So if you answer all other questions nicely, right? So you have done well. But next time we'll be doing a better one. Okay?
Yes, sir. And we have actually not kept it all this because we thought it would be a questions and we would answer it. So we haven't kept.
We'll ask questions more. Time is still there. We'll ask you more questions.
Yes, sir.
If you can remember whatever
Coming to
questions
the-
asked by Supradip sir, you can answer.
Yes,
I'm just reinforcing
And sir
again.
was telling the difference between DK and HHS. How do you?
Yes. The first thing, it's very important precipitate effect. Like in this patient, a young female coming, what are the probable causes you will think? A patient comes alcoholic, what you will think? A patient comes female with a very slim trim, going with the going dieting and other things, then coming with this or some other pathology patient is having. So those are very important clues in the history only, which will pick up what's happening to the patient.
The trigger in her case was we have taken the history for that too, sir. The trigger was under she was having this epigastric discomfort. She was skipping the meals. She was a medico actually. She was working as a DMO. She was not having her food intake was not proper, and she was having this epigastric discomfort. She had to to go for upper GI endoscopy. She was not having the food. She was an NBM, and post procedure also she was not having her medications regularly since this past 3 days and all. This was what happened.
So what is the cause of pain abdomen? So
Sir?
then in that case, you said that she was not taking insulin properly and not taking her diet properly because of pain abdomen. So she landed up in DK. In that case, you need to answer what is the cause of the pain abdomen.
Yeah.
If the pain abdomen is leading to lack of insulin intake, leading to diabetic ketoacidosis, then we must find out what is the cause of pain abdomen. You said during presentation that DK was the cause of pain abdomen. Now you are saying pain abdomen was the cause of. Anda pehle aaya ke murgi. Now dhundo. Find out.
So this is very important now. How do you then find out what is the cause of pain in this patient? Characteristic of pain. What was the pain like? She's getting pain first, or she was went into ketoacidosis, or patient. It's very common presentation that patient gets pain and they are diagnosed first time with the diabetic ketoacidosis. Very common. Patient type 1 diabetes, many patients are just sometimes diagnosed with the first presentation is only pain abdomen only. So what was the phosphate level in your patient? What was the phosphate level?
We haven't checked the phosphate levels.
How important is what is the presentation if the patient goes into hypophosphatemia, which is very common. I was looking at started with the potassium chloride in this patient. We like to give more of potassium phosphate. It's available now. So what is this patient gets a hypophosphatemia and complication of hypophosphatemia. So what sort of the picture will be?
We worsening cardiogenic status,
Respiratory depression.
Okay. Have you seen this hypophosphatemia secondary to refeeding syndrome or diabetic ketoacidosis? What are the different causes of various differentials of hypophosphatemia? One is diabetic ketoacidosis, that's okay. Refeeding syndrome, I already told you. Anything else?
CKD.
CKD. There is high phosphate levels.
Hyperphosphatemia.
There is hyperphosphatemia rather. What else? There are so many patients in ICU which get hypophosphatemia. Burns patient. Patients with the CRT on CRT. Patients, although not common for you people, but a patient who gets a liver failure, once the liver is regenerating, these are patients who get hypophosphatemia. And it's not only the respiratory, suddenly patient may go into cardiopathy, and because phosphate is required for each and every membrane function because it's a part of ATP. If ATP is not there, each and every membrane function will go off and patient can have a cardiac failure, patient can have rhabdomyolysis also. So it's very important. How much potassium phosphate is there in one ampoule? Simple. Have you used it ever?
We have used at a pot closet, but not.
Okay, I'll tell you. There is 15 ml ampoule of potassium mostly. So how much potassium is there? How much phosphate is there? It is same like potassium chloride, or it's a different? We have faced a lot of complication with this also.
Pot chlor, it will be 2.5 milliequivalents. Pot fours, I'm not sure. So
2.5?
in potassium chloride, pot chlor, like each 15 ml will increase 2.5 milliequivalents of potassium.
I couldn't follow.
20 milligrams.
I couldn't.
Each 15 ml of potassium chloride contains 20 milliequivalent potassium, not 2.5.
2.20 milligrams.
She's saying it raises potassium 2.55. You said so?
Yes, I have, but yeah.
No, don't go after this. So much potassium.
There is no formula. There is no formula like this.
There is no formula like that. So how much is deficit in diabetic ketoacidosis potassium? Let's go the simple things.
Less than 1 millimole per liter. If potassium is low, then we will correct.
Any diabetic patient, when he is in ketoacidosis, how much potassium loss you expect? Like patients of potassium was 5.6 in your patient, 5.5. It's excess of potassium or low potassium deficit in your patient. If excess, how much was excess in your patient? And how much is the deficit if you think of any diabetic ketoacidosis patients? Range. I'm not asking the specific any formula. How much expected?
It was purely because of the transcellular shifts, not because of a deficit. It was not because of the potassium deficit per se. It was more because of transcellular shifts we are
So
getting.
you think that the patient was not in a potassium deficit or excess, it was just transcellular shift? That's what you think?
Yes, sir, because they
Don't agree with you. Any patient who is in diabetic ketoacidosis will have a 300 to 600 of a potassium millimoles deficit. That's why Dr. Ghosh asks you, if the patient's potassium is, let's say, 3, what will be your treatment to start? This different scenario, patients rather than 5.6 is came 3. And 5.6 is also in diabetic patient with a potassium deficit. Potassium is just extracellular in this what we measuring. We are not very interested in what is happening. It's all transient. Once you start treating, it will go in. Okay. So if suppose the patient's potassium is 3, what will be your protocol to start with the treatment of diabetic ketoacidosis? Simple things.
Less than 1 millimole per liter, then we will start potassium, sir. Overcorrection also will lead to the hypocalcemia. Then we should monitor calcium.
No, I am not able to accept this. You mean first we 3, whether you will give fluid, whether you give insulin, or you will give potassium, how much potassium you will give, what route you will adopt, at what time, what are the complications if you start directly diabetic ketoacidosis management in a patient with a potassium of 3?
First, potassium should be corrected before starting the insulin.
What is the level, cutoff level where we expect patient to have a no?
It should be 5 millicoulomb should be our.
So you will raise first to 5, then you will start the diabetic ketoacidosis management?
It should be at least 3.5 should be our minimum value.
Okay, 3.3 plus we can give. So, what are the complications if patient gets hypokalemia?
Arrhythmias.
What else? That's patient's potassium is 1. You started erroneously, someone, your junior, started with the potassium, without potassium insulin. And patient's potassium is 1. What are the next you can expect in this patient?
Arrhythmias will be there, hypokalemic pulses will be there,
Hypokalemic paralysis.
So, cardiac and neurological complication are anticipated in these patients. See, when we are taking exam, we always know that you are preparing only the case which you have got. Sometimes the briefing is also there. So, examiner will drift from one angle to the other angle to see your general knowledge. If your general knowledge is okay, we accept. Otherwise, we think always that you have been briefed.
Okay, regarding potassium, there are some misconceptions I can make out from you, my dear Bache. First thing is, usually you will find the potassium is in a normal range or maybe in the higher range in diabetic ketoacidosis. But as Sir is telling, Dr. Gautam is telling, the potassium is actually deficient in the body. Why? Because diabetic ketoacidosis is associated with hyperglycemia. Hyperglycemia leads to diuresis, and diuresis produces loss of potassium to the urine.
Yes.
So in total body potassium is low. But because of the metabolic acidosis, there is a shift of potassium from the intracellular to the extracellular compartment, leading to
Hyperkalemia.
Falsely high hyperkalemia and a falsely high false normokalemia. So the golden rule is, if the potassium is in the ABG, because you do not have the lab reports initially, you have the ABG. If the ABG shows a potassium of less than 3.5, first you correct the potassium, then give insulin. Another golden rule is, even for fluid correction, first correct the fluid. If you give insulin before correcting the fluid, you will produce further hypovolemia, right? Because insulin will also, along with glucose, take the fluid from the extracellular compartment to the intracellular compartment, producing further hypovolemia. So first correct the hypovolemia, then correct the insulin. Volume first, potassium next, insulin next. Right? Regarding phosphate, is very, very important. I can make out from your faces that you have not actually read phosphate. It is very, very essential. It's not only essential for TPN and whatever burn and other things, it is also important for diabetic ketoacidosis. The golden rule for diabetic ketoacidosis is to correct the phosphate if the patient is symptomatic. Symptomatic is respiratory depression or myocardial depression, or the patient has got an absolute phosphate value of less than 1.2. Okay, it is true for you have not mentioned anything about the magnesium. You have not actually checked the magnesium also, which is again a very, very important electrolyte in diabetic ketoacidosis. Along with hypokalemia, you'll also see a lot of hypomagnesemia. Again, if there is arrhythmia, if there is neurological problems, issues, or if the patient's magnesium level is less than 1, you correct the magnesium. Right? So important, very, very, very important. You mentioned one thing about the insulin. You have started subcutaneous insulin in a patient who is ventilated and with respiratory patient is on insulin infusion. How did you manage to do that? What type of insulin was given? And the problem is, if you give, there are, I'll just give a perspective. There are some long-acting insulin. One question was there in the QA box. Shall we give long-acting insulin? When shall we? I'll ask you one question. When shall you start subcutaneous insulin in a patient of diabetic ketoacidosis? Give me a very scientific answer, not from your experience. What is the answer I want as an examiner? When shall we start?
Subcutaneous insulin should be given when we are planning to taper off this IV infusion. It should be started at least, it should be given a dose at least 2 to 4 hours so that its action starts in the body.
When you are managing a patient of diabetic ketoacidosis, we start with insulin infusion, right?
Yes, yes.
And we give a fixed dose of insulin infusion as you have started with 16-minute bolus, it's 16 minutes per hour.
Yes, sir.
So
Now, you want to switch over from IV insulin to subcutaneous insulin. When do you do it?
The anion gap should be closed. The anion gap should be closed. It should be less than, it should be 10 to 12.
And patient should be eating orally?
No,
Yes.
even on.
Yes, patient should be eating orally. Anion gap should be closed, and there should not be any vomiting or pain abdomen. Then only you are supposed to start a subcutaneous insulin. That is the scientific answer. Okay, so what you did is okay, but what you are expected to answer, this is what you are expected to answer. Another one thing you missed is, do you change the insulin infusion rate at all? How do you monitor the insulin infusion rate? How frequently do you check sugar?
Second hourly, sir.
It
Why
should be
second
measured
hour?
hourly, sir. At least, the glucose levels should be reducing at a rate of 50 to 70, the prior value. Then
Good.
our dosing is correct. If not, then we have to double our dosing and check the values, check the reduction values again. Monitor
And
the
when
values.
when you reduce it,
Sir?
when do you reduce it?
When do we reduce it?
You double is too much. Never do that.
Okay.
You mean that if the patient's sugar is initially 350 and now it has gone to 450, you will increase the insulin infusion from 6 units to 12 units? No. No. That means next time it is 550, you will go to 24 units per hour. That's not the way. So there is no formula again. There is no formula. But there is a formula. If the sugar level goes down below 250 milligram per deciliter, you need to start reduce the insulin to half, and you need to start a dextrose containing fluid simultaneously. That's a very important thing. You have not mentioned anything in your presentation regarding this. Interesting? Padna padega, beta.
padna padega. There is one more question. You said how much glucose falls. There are a couple of patients where the levels are not going down. and there are some a couple of patients where the glucose goes very fast down. What are the normal response you expect? And what are the patient, if the patient's glucose comes from 300 to only 50 within 1 or 2 hours, what are your differential then? It's a difficult question, I know. So what are the set of patient where it goes very fast?
300 to directly 50.
Pardon?
300 to directly 50, sir.
Yes, very fast. Normally, what is expected if you saturate all insulin receptors? Then what is a gradual, how much fall you expect every hour?
Should be ideally the same thing. It should be like 40 to 15 milligrams.
Normally, there is
sometimes
75 to 100
50 to
fall in
75
level only, but only couple of patients, especially the alcoholic, starvation, these are the patient and patient with the liver disease. They are patients who have the actually there is a difference in the mechanism of setting in also, because these are the patient with a gluconeogenesis which happens normally. That's also destroyed. It's a little higher level. I think we can forget. There is one question in the chat box about the CT scan and having the ischemic gut. So a ischemic gut normally goes with the high lactate very quickly, and the diagnosis is easy. CT scan is advisable in DKA patients, especially the lactate is also high. If you are thinking of pancreatitis also, once the amylase, lipase, triglyceride levels are high. So these are a couple of things where we have to have the clinical judgment, but still something can go wrong. There is the we cannot advise all the investigation in one go. So that's very important. I think wonderful presentation.
There is a question, sir. There is a question in the question box regarding how much fluid to be given in a patient of cardiac dysfunction with DKA.
Yes,
I think I'd like to answer this question. It's an interesting question.
Very good.
So we need to understand what are you expecting by giving fluid. So initially we give fluid to correct the hypovolemia. So we give the fluid to correct the hypovolemia, whether the patient has got cardiac dysfunction or doesn't have cardiac dysfunction. What I mean by hypovolemia is you correct the perfusion defect. So you give fluid, and traditionally it is expected that you give 2 liters of fluid followed by 250 to 500 ml per hour. That is probably doesn't have any scientific basis. For every patient, we start with 15 ml per kg body weight, or say around 1 liter of fluid, whether the patient has got cardiac dysfunction and doesn't have cardiac dysfunction. Because overall, in diabetic ketoacidosis, around 4 to 6 liters fluid deficit is expected. So you give 1 liter of fluid, and then you give boluses of fluid based on a genuine or reasonable understanding whether the patient has a volume responsiveness hai ya nahi hai. So that's probably the way. You have to individualize the patient, individualize the thing, and start giving fluid. Don't worry. Cardiac dysfunction se kuch nahi ho jayega. Agar DK sahi mein hai to.
Another thing is even AKI patient also. Sometimes these patients come with the high creatinine and urea and no output. Even then we have to replace fluid and see most of the patient will come up with the urine after some time. We should not hold fluids just by seeing the creatinine.
And beta Shwetha,
Yes, sir.
too much of emphasis on adequate urine output in diabetic ketoacidosis, as Farid is telling very clearly, is not accepted, because urine output is not a judge, is not a good judge for volume status of this patient in such situation. Because glucose is a osmotic diuretic. So hyperglycemia per se will produce a lot of urine, although the patient is actually volume deficient. So urine output of 80 to 100 ml, that doesn't mean that patient is not hypovolemic. It can mean that patient is still hypovolemic. And until unless you correct fluid, you can still end up in problem. Okay? So there is some questions in the question box. Any role of RRT in these patients with? Kyun karna hai bhai? RRT is to be done for patients with non-correctable metabolic acids. This is ketoacidosis. These are metabolizable acids. So if you correct fluid, if you correct the relative deficiency of insulin and excessive counter-regulatory hormone, this is the pathophysiology of diabetic ketoacidosis. You have relative deficiency of insulin and counter-regulatory hormones like glucagon, adrenaline, and the cortisol is high. So if you can correct that by giving adequate fluid and replacing the insulin, your ketoacidosis are going to be metabolized. So why do you need an RRT to correct it? You cannot have a mechanistic approach to medicine. You need to have more rationalized approach to medicine. So RRT has a role only for like if the patient has developed an established AKI, the tubular necrosis leading to standard indications for RRT, not for correction of the ketoacidosis. I would like to differ with both Gautam sir and Shwetha ji. I would not like to give non-invasive ventilation or HFNC in such patients. This patient is dyspneic, which looks like dyspneic because patient is severely acidotic. So if you give NIV to such patient with such a huge respiratory effort, you can actually land up in PCD, self-induced lung injury. Patient's transpiratory pressure swing will be huge transpiratory pressure swing. हर चीज का mechanistic solution नहीं होता है. Huge transpiratory pressure swing will lead to more ventilator-induced lung injury. NIV, you deliver a fixed level of alveolar pressure, and patient is generating huge pleural pressure. You can imagine what will be the lung stress. Stress will be huge. So you will actually land up in that. If at all you need to provide ventilatory support, it has to be paralyzed and ventilate. Otherwise, just wait. Give some low high liters of fluid. You'll be okay. Patient will be better. I
didn't say for that. If the patient, we have to, that's why my question was, what is the expected CO2? It's very important piece.
Accordion में discuss करेंगे.
Yes.
आप और मैं तो accordion में discuss करेंगे. We'll discuss in accordion.
Yes. So,
for these kids.
No. So we hand over to Dr. Kaladhar because it's already 8. So
yeah.
Yes, sir. Yes, sir. Thank you, sir, for the great discussion. Actually, it can go up to 8:30 also, sir, if you are interested.
Somebody has asked about indication of soda bicarb.
Yes.
So there is no data. There is absolutely no data of indications of soda bicarb. People give empirical soda bicarb. Actually, if you see, you don't give bicarb, you give sodium. You give sodium, you produce high strong ion difference and you correct the. But for non-metabolizable acids like lactic acidosis or ketoacidosis, shall we give soda bicarb? That's quite questionable. But the majority of the people, including me, we give, like you have given, we also give sodium bicarbonate. If the bicarb is, if the pH is less than 6.9, or some people say less than 7. But these are not based on any strong physiological rationale or clinical evidence. These are based on absolute empiricity. Empirical. No clinical evidence. No physiological rationale. ये जब देना है चलो दे देते हैं 6.9 के ऊपर हमें डर लग रहा है तो दे दे. Because we are scared of 6.9, so you want to give. But whether it has got any rationale, we don't know, because it actually paradoxically can produce cellular acidosis, it can produce alkalosis and electrolyte disturbances, particularly hypokalemia.
Yes, sir. Yeah, how to approach to HHS management, sir? Is how it is different from DK? Any like few points on your side?
The biggest difference is HHS. We need to find out because HHS is usually found in elderly age groups with a lot of comorbidity. Many of them are apart from diabetes, many of them has got CKD, many of them got a previous ischemic heart disease or ischemic. So there, and the second thing is HHS. DK, their patient usually presents within 2 days or 3 days, but HHS patient can take 5 to 7 days. They are more dehydrated, they have more comorbidity, they have more age, so they have a worse prognosis. So volume correction should be more aggressive in hyperosmolar non-ketotic state compared to diabetic ketoacidosis. Looking for cause, precipitating cause should be more aggressive in hyperosmolar non-ketotic state. And believe me, the commonest cause is pneumonia or UTI in elderly patients. And don't forget MI and stroke. So look for this. Another thing I find HHS is sometimes very difficult to diagnosed in the presence of cerebral venous sinus thrombosis. These guys come with elderly gentlemen. They've come up with altered sensorium, and they have a venous sinus thrombosis as well as HHS. Otherwise, giving fluids, giving insulin, giving potassium, magnesium, phosphate, basic principles remain same. But what prognosis that needs to be understood, need to be more aggressive in volume correction, and need to focus more on attention on the correction of the precipitating cause in HHS compared to the DK. That's what my take on. And HHS unfortunately has got very little data compared to DK. DK has got more data.
Yeah. Another thing important is very important to monitor effect of osmolarity. That's very important. Go on monitoring that, because sometimes patient is having even today I saw one patient where it was sugar level was around 800, 900. But when I calculated the osmolarity was only 320. So sometimes these present, very important point is Dr. Ghosh mentioned, they present over the days, there will be more of a sensorium alteration, and very important to monitor these patients that aggressively. They have much more high mortality as compared to DK.
Great point, sir. I think that is very, very important. Correction of sodium in patients with hyperglycemia, because sodium is falsely low. You have hyperglycemia, the fluid is drawn from intracellular compartment to the extracellular compartment, so you get a falsely low sodium value. So you need to correct for every 100 milligram per deciliter, correct by say 1.6, 2 variable, again empiricism. But need to understand that hyponatremia in the presence of hyperglycemia may be a false marker. So you need to correct that. So the different books suggest different. In my book, it is 1.6. Dusra book mein kya hai, pata nahi.
Sir, I have a question.
Yeah.
As you said, HHS is more people be having more comorbidities and elderly people. If suppose a CKD case who is almost oligoric but not on any maintenance dialysis, if he presents with a HSS, should the volume repletion be same in them as when compared to the others? And
Regarding volume replacement for every patient, it is same. It is same. We need to understand why are we giving fluid. We give fluid to maintain tissue perfusion. Whether the patient has got underlying CKD, patient has got cardiac dysfunction, or patient doesn't have anything. So you give fluid, and for every patient, giving blind fluid is not correct. Blind fluid, giving 30 ml per kg body weight or 40 ml per kg body weight or 2 liter volume. No, you give volume 1 or 2 liters. So one thing is, for whenever there is a DKA, you expect that 4 to 6 liters of volume deficit in the body. Similarly, in HHS, it can be more. It can be even in the tune of 6 to 8 liters. So giving initial 1 or 2 liters will not make any difference. But subsequent volume, you should have at least enough understanding this patient will be fluid responsive. You don't need to do some PLR or do some tests. Even with a general idea that, okay, this patient probably will respond to fluid, kuch to idea lagao, then give the fluid. So maybe you give small boluses, 250 ml boluses, 4 ml per kg body weight boluses, and see whether the patient is responding. How do you check the response? You check the capillary refill time. Check the capillary refill time in a standardized manner. Or you check the lactate, or check the mottling score, check the consciousness level of the patient, and see what is the response. The way Thomas Leta has initially suggested in 1832. Give some fluid and see the response. So it is true for everybody. CKD hai, nahi hai.
I understand the question. Actually, I have another assignment. Can I leave now?
Sir, we all should leave. My wife is waiting, otherwise she'll beat me up.
My wife is scolding me in front of me. You can't see her, but I can see her.
Sir, just one more question, sir.
Yes.
So, if there is a hypernatremia associated with DK, suppose sodium of
Yes.
around 145, 150.
Therefore, you want to answer very quickly. See, once the hypernatremia is there, that means the patient is too much dehydrated. That is much volume depleted.
Yes.
It's very important. That is much more dangerous than this. But once you start replacing the fluids, that's we can start with the hypotonic fluids. It will be balancing it, but ultimately patient will need once we should not go with too much corrections also, because osmolarity is very important in these. HH patients can have a hypernatremia and the osmolarity maybe in 350 or so. You have to see it should not go. And we are important is to see the effective osmolarity, because urea will not lead to much of problem, because that's it goes on to and fro of the membrane very easily. But sodium and this glucose are very important. So that is the thing important to see in this patient, but we should be slow in managing. Maybe the patient can land up with cerebral edema. So thank you very much. I think.
Thank you. Thank you, sir.
Yes, sir.
Thank you, sir.
Thank you, PL Gautam sir and Supradip sir, for your valuable sharing the clinical experience and guiding our students. So thank you, Shwetha and Hemalatha, for bringing out that case for a nice elaborated discussion. And once again, thank you, sir. Good night.
Thank you. Thank you.
Thank you, sir.
Good night.
Namaskar and Jai Bharat.
Namaskar. Namaskar.
Namaskar. Thank you.